Hi everyone, I'm Rachel. I am a Sustainability and Quality Improvement Lead at Centre for Sustainable Healthcare. If you haven't heard of us before, we're a fairly small charity, there's about 30 of us, and we support the NHS and other healthcare organisations internationally to reach net zero goals and wider sustainability goals as well. And I'm here with Michael. We're going to talk about the Design for Life programme and in particular a project focused on reuse of specific products. Do you want to come up?
Thanks. You're definitely in the right room for accents. I love it. Thanks Rachel. So I'm Michael Hopkinson, so I'm Head of Supply Resilience and Sustainability in DHSC's MedTech Directorate, so Medical Technology and Innovation. And my team lead on Design for Life programme. If you haven't heard of it, it's our programme to deliver a circular economy for MedTech by 2045. So a little bit like we were talking about with food waste earlier, it's all about getting away from single-use MedTech products and towards a future where we see a lot more reuse, remanufacture and recycling. So we use this kind of butterfly diagram on the right-hand side there just to kind of get across the message that it's about delaying that incineration end-of-life stage as far as possible on the medtech products that we buy. So through those three processes, can we kind of maintain the value of our products for as long as possible? We've got a purposefully broad definition of what we talk about when we talk about medtech products. You can see it on the screen there. We did that on purpose because we think the range of medical technology products is vast, absolutely huge, and there's so much scope for opportunity to support a circular economy. So we've quite purposely left it as broad as we possibly can. Thank you. So this is why we're doing this programme really. So 4 objectives. So anytime I talk about this at conferences or whatever, I find myself constantly saying this is not just a sustainability programme. Sustainability, obviously, net zero, hugely important, and we 100% believe and push that Design for Life, a circular economy, will help deliver the NHS net zero targets that we're all a part of delivering. But it was actually born out of supply resilience. So the programme came about after things like COVID, Russia, Ukraine, more recently tariffs even. I'm sure people in the room have experienced the impact that those kind of things can have on in healthcare and in patient care. So the idea for a circular economy in medtech came from, if we can have products closer to patients where we're not reliant on those kind of overseas volatile supply chains, we can avoid those detrimental impacts to patient care. So it was born out of resilience. Sustainability is an obvious objective and benefit of the programme, and then cost savings, which we heard about earlier in the food sector as well. We think cost saving potential here is absolutely huge, given the vast range of products that we're talking about, and growth as well. So growth obviously being a massive objective for the government, and when we're thinking about new high-skilled jobs in areas like remanufacturing devices, recycling, decontamination, which is a massive part of what we're doing as well. We think there's a real opportunity to add a lot of growth to the economy there as well. So that's what the kind of big programme is. That's why we're doing it. Those are the objectives. We work with CSH. 2 reasons really. We published a strategy, which if we've got time I'll come on to, last year. And in our first year after publishing the strategy, we were really keen to both kind of fill our evidence gaps. So what kind of evidence gaps do we need to fill to be able to scale this up at a national level, which the project's definitely helped us with. And also what can we do to kind of demonstrate impact right now. So we've published, but we want to get people on side. We want to build the momentum in the system. What can we do to generate that? And particularly in the kind of sustainability and cost savings area. I won't steal your thunder, but that's the kind of focus that we had for the pilots to help us kind of take this forward. So over to you.
Cool. So as Michael just mentioned, we worked together to put together this policy brief, so transition to reusable medical products in NHS hospitals, looking at current practice and particularly challenges and barriers that sites are experiencing. And we worked really closely with Brighton and Sussex Medical School, who co-delivered the project with us. So in terms of the aims, so first was to quantify the benefits, as Michael just said, to NHS trusts and health boards. So we had some sites in Wales as well, from transitioning from a single-use to a reusable item, focusing on specific high potential items identified from Department of Health and Social Care, and to better understand the challenges faced for these transitions. And so at CSH, we worked with 10 sites. We had 4 in Wales working as a collaborative and evaluated 6 different items. We had a really short time frame for this project. I think it was about 11 weeks. We didn't oversee or support the transition and implementation in those sites, but we kind of looked at what was currently happening, where they were in that process. Some of them had already started, some were just planning, some had been using the reusable for some time. And then, had a look at that kind of snapshot and projected what the potential savings or costs would be if they were to roll that out across their service or implement in specific areas. And then Brighton and Sussex Medical School conducted 13 interviews with a range of NHS staff and analysed the data from those into different themes. So in terms of the items selected, they're listed there on the left. I won't go through all of them just now. And the outcomes we were exploring were around the process and approach, the barriers, any patient experience or safety impacts, any impacts on staff experience as well, and then the carbon emission saving or cost and financial saving or cost. And the sustainable value equation there is we use that in pretty much all of our work at CSH. It's just highlighting that if we're only focusing on the environmental impacts, we're not going to be truly sustainable. We always have to think about all of these things together. So this is just to acknowledge our participating sites. So it's not always easy and organisations don't necessarily want to share if they're having challenges and barriers and if things haven't been implemented in the way they would ideally like them to be. So we're really grateful for them for sharing that learning, because understanding why and when things don't go well is hugely helpful for being able to get it right in the future. So in terms of the process and approach, there were really similar governance and approval requirements, essentially all the boxes that needed to be ticked across all organisations, but the implementation approach really varied. So the order in which all of that governance and approval happened was really mixed. The lead of each change was very different. It was very driven by clinicians in some organisations. It was very driven by procurement in others, as 2 examples. Some organisations implemented small-scale trials first to really assess how the transition might work in reality before rolling out, whereas others went for kind of trust-wide implementation as much as possible from the beginning. So despite having similar kind of tick boxes that needed to happen, there was really inconsistent ways in which this process was approached, like I just mentioned. There was also inconsistent product usage at baseline, so some organisations understood that they were only using single-use products, but when they actually started to understand and kind of investigate further what was happening in their trust, they found some wards in the hospital already had reusable items, some still had single-use, some were using a single-use item as if it were a reusable item, which is against the guidelines for that product. The steps were always mixed. There are a huge number of stakeholders that need to be involved, and that makes things quite challenging as well. It also meant some key staff might be missed out. So porters were left out of key discussions for one product, but they were actually really essential for making sure those products got from where they were used to where they needed to be laundered. And so them not being involved in those initial discussions led to some implementation issues later on. And one of the key findings was that these changes are driven by very motivated individuals rather than any kind of formal support structure. Training and communication challenges occurred in quite a lot of organisations. There was limited training capacity. That was both from internal staff who need to provide training. So as one example, manual handling teams for slide sheets within the organisation. Being able to train an entire trust in how to use a new slide sheet is quite a big task, but it could also be from the perspective of staff being released from their clinical duties to have the time to attend that training. So from both perspectives, that was challenging. And so it wouldn't always reach staff in time, which could lead to risks of incorrect use and also reduced confidence from staff. And the clinical acceptability and perceptions varied. So some specialties felt that single use worked better for them. Others felt very strongly that reuse worked much better for them. And unfortunately, there were some conflicting guidelines and research. So in one trust, one team used reusable bronchoscopes, another team used single-use bronchoscopes, and they had actually wanted to reduce their carbon footprint, but they found a paper that reported the single-use bronchoscope had a better carbon footprint, a lower carbon footprint than reusable, so they'd kept using single-use, despite our findings in this research being that the reusable was a lower carbon footprint for their organisation. There were a range of different infrastructure, capital investment and cost barriers. So storage and compatibility, being able to track items if they're reusable, if they're going somewhere to be laundered or sterilised and coming back, how to kind of manage that and ensure things aren't going missing. There were some perceptions on what was the most appropriate transition, if there were different options available for reuse. Some items required significant capital investment, so new washers to be able to fit the containers in sterilisation machines. And then, there were risks. Actually, I'll come to that point later in a case study. And there were also data and carbon accounting gaps. So very few sites conduct their own carbon analysis at such a specific level as individual products. And a lot of staff lack the time, the confidence and the expertise to be able to do that. So it was our sustainability analysts that estimated the carbon footprint for all of the products except for one. And they still required support. And I already mentioned there's conflicting guidelines and research. In terms of perceived changes to patient safety, usually the risks were due to kind of training gaps and confidence rather than the products themselves. Some teams felt strongly that reusable products increased clinical acceptability and functionality and provided better patient care. In terms of infection prevention and control, in all cases, IPC perceived any risk to be extremely low with the transition, but having said that, there's still obviously policies and protocols they need to follow and implement. IPC were really engaged, they were really willing to see these changes happen across all of the sites, but the IPC staff we did talk to acknowledged there is a lot of variation across IPC individuals, but also across teams, across different sites and organisations as well, and that the risk acceptance might vary. So one change might be accepted in one organisation, but not accepted in another. Changes to patient and staff experience. So for a lot of the products we looked at actually are used in surgery, so patients are often asleep, they're not really aware of if the product is changing, so there's not going to be any impact on their experience. For staff, there's a lot of positive experience reported. So for some of the items, it was felt they were much easier to use, they were more reliable. Staff, they were happy to see that they were reducing their environmental impact and reducing waste. But there were some concerns around increased workloads for sterilisation, time for cleaning if it was a product you cleaned at the point of use, so the responsibility was then on clinical staff. And there were comments around inefficiency in current systems. So we spoke to a sterilisation service who were quite frustrated by knowing they were sterilising items that were going back to clinical areas, sitting unused, the sterilisation would expire and it would come back and be cleaned again, and they knew they were cleaning products that weren't actually being used. In terms of CO2 equivalent, all of the products we evaluated had a lower carbon footprint across a year compared to using the single-use item, but there was a risk of increasing the carbon depending on a few different factors, specifically around how the item was sterilised. So with a more energy-intensive washer, the carbon footprint of a reusable tray wrap was higher. The financial impact varied more than the carbon impact. So some projects had a clear saving, but for some of the other items, the costs varied. And this was mostly due to the reusable suppliers having a lifespan based on a time frame rather than a number of uses. So the main finding from that is that the carbon and financial impact are really dependent on a lot of local factors. And this is just a quick case study that illustrates that. So in Northampton, they compared patient warming devices, which have some very fun names of bear huggers and hot dogs. So the bear huggers are the single use, the hot dogs are reusable. They had been using the single use bear huggers for many years, but had purchased some reusable a few years ago and had training at that point on how to use them and how to clean them. They're an item that's cleaned at the point of care using Clinell wipes. They don't require sterilisation or laundering elsewhere. But they experienced several challenges. So an audit had previously found there was a decline in core body temperature for patients when they used the reusable item. The whole purpose of using these patient warming devices is to keep patients warm, so that's a very big concern if it's not keeping patients' core body temperature high. However, that audit was conducted whilst the reusable item was not being used correctly. So they audited based on the reusable item being placed under the patient only, whereas the guidance for that product is it's placed under and on top of the patient. So the findings don't really indicate if the product is acceptable when it's used as it's supposed to be used. But that led to some barriers with teams not wanting to use them because they had a perception that they wouldn't be safe. So the improper usage I just mentioned was also one of the other issues, and there was also issues around confidence of staff in knowing how to use them correctly or in trusting that they were going to work and keep patients warm. And so the impacts, they ran another audit and they confirmed that patients were being adequately warmed, but there was still a mix of practice. There are some benefits to using the reusable because it's much quieter, and we know that in theatres there's a lot of noise that can impact on staff communication. They had quite a significant carbon saving, considering it's about 10 different theatres, I think it was. But the financial impact varied depending on whether they implemented this in only their main theatres or across all theatres. And that's because the lifespan of the reusable item is 2 years. And so in main theatres, they use them so often that the cost per use is lower. But in their other theatres, they're using them less often, so the cost per use is essentially higher. They had really mixed feedback from staff, I think linked back to the historical audit that wasn't looking at the appropriate use of the reusable. So there's work to do there around education and training still for staff, which is the next step. This is some of the quotes that came through the other aspect of the project from Brighton and Sussex Medical School, but I'm worried about time and giving Michael a chance to speak, so I'm going to skip over them. And essentially, they reinforced the message from the pilot site, so there was a lot of alignment in the types of challenges that everyone was experiencing. So I've spoken about a lot of negatives, a lot of challenges, a lot of barriers, but there are a lot of positive takeaways that came from this as well. So despite all of these issues, there is change happening, and there are really great examples of reusables in practice working well and everyone liking them, patients being happy. And there are these really motivated individuals who are driving this, and they're doing so against all of these other issues. So we really should be able to support them so that we can have faster, more consistent transitions at the scale and the pace that we require. There is a willingness to transition. The clinical effectiveness for some products can be improved. So for bronchoscopes, as one example, an endoscopy team that we spoke to felt very strongly that these improved their patient care to the point where if they couldn't use the reusable item, they would suspend their service until it was available again. They would not default to single use because they didn't believe that they could provide adequate care. And while there is local variation, there's really strong support that reuse lowers environmental impact. And so we ended the report with 3 recommendations, and I'm going to hand over to Michael now to talk about these. Do you want this?
Thanks. So what are we doing about it, I guess, basically? So how are we taking this forward now? I made quite a few notes, actually, in the earlier session. It's really interesting that there's so much learning from food waste as well that I think we can take into the medtech sector as well. So this idea, the first one around kind of system level leadership from the top down and centralized guidance for the kind of scale and speed of change that we want to see. Listening to Royal Marsden earlier, it's a similar thing that we meet like amazing sustainability champions who are working in medtech across trusts across the country who are pushing the agenda forward and who are crazy passionate about delivering this and scaling it up in their own trusts and getting everyone on board in the finance team, in the procurement team, in the nurses, doctors, everyone. but we can't rely on them. It wouldn't be fair to rely on them to try and deliver the scale of change that we're trying to deliver in this programme. It's got to come from the top and centralised so that we can have that kind of push that everyone's moving in the same direction. So we totally take this one on board. From an approach perspective, I think there's kind of two sides to it. You can see on the prioritisation framework point there, there's one kind of what are we going to focus on? So like from the department and from NHS England, who we're working with on this really closely, what products are we going to focus on? So what products do we think we can scale up across the piece? Starting with the ones, taking the point earlier that there are no quick wins, but what are the kind of quickest wins, the easiest ones, where we're spending the most money, where decontamination's relatively straightforward, where it's not going to add to people's workflows. Those are the ones that we can try and push and scale this up. And then the second part of that being what support can we wrap around it, which brings me on to the second one. So what are the kind of guidance and documentation and training that we wrap around those products so that when we do push that out there across trusts across the country, people can implement it without having to, as I'll say in a second, go through pilots. So one of the things we've found we hear quite a lot is this kind of idea of pilotitis. So every trust feels like it has to do its own pilot before it can implement a change, rather than them being this kind of top-down direction that, no, we have the evidence, we have the support materials, we have the guidance in place so that whoever it is can go ahead and do this without having to go through their own pilot project and kind of delay the benefits that we're trying to realise. And we had a similar event where we presented these results at Westminster a couple of months ago, and one thing that really struck me was we had different trusts in the room, and on the IPC, the example of infection prevention control, we had two trusts who were kind of sat opposite each other in the discussion afterwards, where one was saying they did the hot dog work and switched to it, and it was absolutely fine, and the trust opposite, which wasn't that far away geographically, just said we weren't able to do that because our local IPC guidance is completely different to yours. And I think those kind of things are the kind of things that we need to, from the centre, try and particularly for products where we think we can make the switch across the board. I think those are the kind of things that we need to address in the guidance and the materials that we wrap around that support that we provide to trusts to make the switch. So we're working with NHS England on both of those first two recommendations. We're working with Liam's involved in that. We're working with stakeholders across kind of clinicians, procurement, IPC, facilities, everyone really, to help us come up with this kind of what are the products we want to focus on, and then what is the guidance and materials that we put around that to help people make that switch as quickly as possible, although albeit in a very complicated system. It does take a little bit of time, but hopefully as quickly as possible. And the third one being around, I kind of touched on building our evidence base earlier, but being open, I think, and honest about the challenges. I think the report that's out now that I'm sure Rachel will touch on, which you can go and read, and you can go and read all the individual reports from the sites as well that took part in this, is really open and honest about how difficult and challenging this is. It might seem simple on the face of it to kind of switch from a single-use device to a reusable device, but the processes involved in that and the amount of people involved who you need on side in the trust and all the different teams that need to be involved, it is really complicated, and there are challenges involved. So I think the report does a really good job of kind of highlighting what those challenges are, and it's now our job with NHSE and other partners to kind of go away and find the way forward that everyone can take forward and implement in their own locality. I think we want to use this evidence as far and wide as we can. The learning from food, I'm really interested in building what we can learn from other industries as well, other sectors within healthcare, so we can kind of take their learning on board as well. And patients, I think, is a really big one as well for us. I think patients for us is probably more of a untapped resource than it is in the kind of food examples. It feels like food's really on top of that. I think we definitely do need to consider the patient role in this. both from the perspective of kind of their views on reusable, remanufactured devices, but also kind of niggling me is whether patients can really help us drive some of this forward in terms of patient choice in what kind of devices and products they're treated with, both in kind of acute settings and in the community as well. So another area of work that we're looking to drive forward is what's happening in the community, not just kind of in secondary care.
So just to highlight, the report is now available very recently through our website, the Brighton Sussex Medical School site, and I think, is it on your website as well, or will be soon. So that links you to our site if you want to read it. I think we can share the slides with everyone after as well. And just to highlight, if you want any support yourself or to read other case studies about reuse, but also other projects that have taken place across the NHS, we have hundreds in our networks and our resource library. So we've got over 30, I think about 33 specialty networks now. And within those, you can access different resources. So it's a really great place to access those, view case studies, research, but also connect with others who are looking at driving sustainability through healthcare. We've got open access resources for teaching about sustainability within healthcare, but also in terms of implementing projects like reusable switches on our SusQI, so Sustainability and Quality Improvement site. So I'd encourage you to have a look at that, or you can signpost others who might be interested. It's quite focused on supporting clinicians, so if you're working, I don't know if anyone here is clinical, but is also worth sharing with your clinical staff as well. We have a range of different programs as well, so if you're looking for some more specific or tailored or in-depth support, these all require funding, but we're very happy to work with you. So if you have any questions about those, there's lots of information on our website, or you can come and speak to me as well, and then I'll hand back over to you.
Literally 2 seconds. So if you are bored on the way home and want to read a strategy, the roadmap is our kind of plan for delivering this over the next 20 years. So please do have a look. There's 6 kind of problem statements. Basically, those are the 6 areas that we need to address to make this happen. Web address is there as well if you want to get involved, or if you want more information, or if they think you're doing something that links to this, please do get in touch. We try to be as open as we possibly can with as many people in the sector as we can. And similarly, we have a website that the University of Exeter hosts for us. And one thing we're really keen on there is like case studies. So anything that anyone's doing out there that's kind of living design for life and promoting the vision, please get in touch. We'd be more than happy to feature it on there.